Hello, everybody, and thank you for joining us today. We're expecting quite a large group today, so we thought we'd let those that were waiting in the wings in early, and so we can crack on and make a start because we've got a fantastic session for you today. As a starting point, I'm Jo Stanford. I head up the Healthcare Project and Change Association, and we're doing this in conjunction with the Federation for Informatics Professionals, and I'll hand you over to Sarah in a minute to tell you a little bit more about that. And then we've got two fantastic speakers with us today. We've got Julie Atkins from NHS England, who'll talk a little bit more about what she does, and Tara Marshall, who from These Hands Academy, and who will talk a little bit about herself and her project. But I won't steal their thunder. So as a starting point, those of you that are here now, it's fantastic to have you with us. We have a Menti poll just to get an idea of who we've got as part of the session today, because we're bringing the different professions together. So if we can get the link in the chat to get started with which sector you're from, and then we'll also have a look at maybe which professional body you belong to as well. So whilst we're dropping that into the chat, what would be really good is for those of you that are here already, if you could just introduce yourselves in the chat, that would be fantastic. We will be taking notes and we will be recording this. So if you have AI note taking, if you could turn that off, please, because we can provide you with summary of notes. That'd be fantastic. Thank you. So QR code is in the chat. So click on the link or scan the QR code and we'll get started with taking note of those. Just while you're doing that, I'll tell you a little bit about us. So the Healthcare Project and Change Association is a not-for-profit community interest company that was set up to support the development of the profession in the healthcare sector. So we're here to provide support to the profession, but also to everybody that is involved in projects and change across the healthcare sector, which is pretty much everybody. We work very collaboratively with the other associations for the non-clinical professions, including FedIP. We are UK-wide and we have regional networks in Scotland, Wales and Northern Ireland, as well as across the regions in England. It is free for everybody to be a part of the community. So if you're interested in projects and change and you'd like to find out more and be a part of it, you are very welcome to subscribe, and that will give you information about free resources, but also links to our events that are coming up and news and things like that. So please do sign up. But also we're here to support the development of the profession and workforce and how we can build capacity and capability across the healthcare sector to help to make it sustainable for future generations and a great place to work so that there's good career pathways. Next event we have coming up is one on information governance, and this is always a challenging one, so good to learn from the actual information governance experts themselves on how to navigate that as part of your project. That can often be a stumbling block, so do come along and find out how you can work more collaboratively with them to accelerate your project delivery. More webinars are going to be coming very soon. We're just actually building a new program for the autumn and winter season. So do subscribe, and on the website, you'll see more events coming up. We have a number of regional network leads coming up, and you are welcome to go to the one that's nearest to you or to go to any of them. And it's a really great opportunity to connect, network and share both your knowledge and experience, as well as accessing that of others in the community. As part of what we do, we develop training and development for project and change management in the healthcare sector, and some of the courses that we have available are accessible to everybody. We have some free online learning modules, and then we've got some essentials programs that are really fantastic for building that first and second level of skill. And given the challenges that everybody is under at the moment across the NHS, we're just developing a programme that's going to come out shortly, which is about recognising all of the pressure that people are under. So looking at change under pressure and what we can do to support you with the challenges that you're facing, whether it's at national, regional, ICB or local level, because we know everybody is going through it at the moment. So there's going to be some free resources to help people through that challenge. some really low cost options to help people and organizations navigate some of these changes. And then for those that want some bespoke support to help them and their organizations, there's going to be options there as well. So do check on the website for more details. If you subscribe, you'll get more information coming soon. So we've got some fantastic change management courses, and these are really great at a time when change is everywhere and it's complex. So do have a look at our change management courses, and also storytelling, because part of change is about how you take people on the journey and get people to go on that compelling change. So do have a look, and have a look at the storytelling as well as the change management options that we have available. So organizational membership will help you and your organization with its journey through the changes, but also helping to build maturity once the dust has settled. The ones that are going to do really well in the future are the ones that plan for a positive and structured and well-balanced future. So think about what organizational membership could do to support your organization when the cuts have been made. But also it's about capability development as well, and there's a lot in there to support that capability journey. So passing on now to Sarah Scriven from the Federation of Informatics Professionals. I'm going to get her to tell you a little bit about what that association does and how we're working together. And this is the third of 3 events. If you haven't seen the previous 2, they are on both of our websites in terms of watch on demand. But Sarah, can I pass over to you for you to share a little bit about FedIP?
Lovely, thanks, Jo. Good afternoon, everyone. It's nice to see a lot of familiar names cropping up. So as Jo said, with Federation for Informatics Professionals in Health and Care, the Federation brings together professional bodies from across health and care informatics, from data analysts to clinical coders to clinical informaticians. We're a broad church in terms of the disciplines we cover, and really want to acknowledge the fact that it's very important we need to work across all those disciplines together, and including partners such as HPCA, because we all need to work to get our projects completed. It requires a lot of discipline cooperation. So it's really a pleasure to be here to be with HPCA doing this series. FedIP, for those who maybe aren't familiar with us, our primary purpose is our public register. So the register provides an avenue for health and care informatics professionals to become professionally registered. So that's very dual purpose in that it gives employers and the public confidence that the professionals who are designing and handling and supporting their digital health systems are meeting a standard of competence, working to ethics and a code of conduct. But it also gives individuals that way to say to their colleagues, look, here are the competencies that I've met. I've got my professional credentials. I want a seat at the table. I want my voice taken seriously in the decision-making process. So the FedIP standards were created in conjunction with the 6 professional bodies that make up the Federation, which are AFA, BCS, CILIP, CHIME, IRIM, and SOCOTIM. If you want to know what the acronyms stand for, you can find them on our website, because it would take me several hours to say them all aloud. But together they represent, as I said, most of the informatics sector across those specialisms, and each of those professional bodies have a license to award professional registration to their members. So if you're interested in becoming professionally registered, please do go and check out the relevant professional body for you. And I just wanted to mention, for anyone on this call as well, part of our mission is really to provide access to CPD as well, because we know how important that is in keeping up to date. But sometimes it's a bit of a struggle, always time-wise, to do it, but also just the time it takes to find the CPD. So we want to try and remove as much of that barrier as possible. So if CPD within the digital health sector is something that you'd be interested in, I would really recommend the FedIP Hub. There's a 6-month free trial, and you can access everything on there that we offer, everything from our professional bodies, but also partners like the University of Edinburgh and other educational institutes. We've worked together to produce some CPD. I won't go into everything that's on there. Please feel free to check it out yourselves, but it's all free, and I really encourage anyone who's interested in doing some more education to look into it. But I'm going to stop there because I want to be able to dive into all of the excellent speakers we've got today. So Julie, if I could pass over to you. But thank you, everyone. It's nice to see you all.
Thank you. I should be sharing my screen now, is that right?
That's
Yes.
great. Yeah.
Brilliant, thank you. Thanks to both for asking me to join you today. So my name's Julie Atkins. I'm the Change Management Lead within Digital Transformation at NHS England, supporting digital adoption across a range of our products and services. So I'm going to talk to you about how we make that happen by putting people first to enable lasting change, and start with just a quick show of hands that you don't need to do that. I think we've got the graphic to do that. See who wants to change, particularly in the NHS. Then who wants to change? Well, fewer people have got their hands raised. And finally, who wants to lead change is always very difficult. It's really hard to get people to take on that mantle. So I'd like to start, please, if I can, with a quick poll. So what we're looking for is, what percentage do you think, how would you split the impact of people, process and technology on successful digital transformation? What percentage do you think should be people, what percentage process, and what percentage technology? Okay, you should see the Menti code there now. Oh, people's getting a lot. Oh, it's going down. Brilliant, thank you. So how would you split the impact? Fairly well agreed that people is quite a bit higher than process and technology. So can we move to the next question then, please, Helen? How do you think attention's typically divided across people, process and technology in digital transformation? So this is, we've just talked about how it should be. How do you think it really is in your organisations? Oh, sad but true, isn't it?
Absolutely.
Yeah. Yeah, so often the case. And it's technology's going down a little bit, but people's gone right to the bottom again. Okay, thank you. So I think what we've just agreed is that technology should be the least important, with process being more important, and then people being the main element of digital transformation success. And this is borne out in lots and lots of ways. So one example is, for example, that Nick Sinclair, who is the former director of ops at Maidstone and Tunbridge Wells, was implementing teletracking, which is really very technical. But he said that implementing it, their teletracking, was less about technical solution, more about trust-wide changes. And he reckoned it was 10% tech and 90% change management. So again, in the Menti, but I'm not going to share the screen now. I'm going to ask Helen if you'll just give me an idea, please, of the answer to those questions. There should be a Menti on there now about, according to McKinsey's research, what percentage of change programs do you think failed to achieve their objectives? Helen, can you give me a shout when we've got some numbers?
Yeah, we're currently on 41%.
Okay, quite low then. Okay, according to McKinsey, it was 70% in 2015. So if we move to the next one then, according to Ernst & Young in 2022, what percentage of senior leaders do you think have experienced at least one underperforming transformation in the last 5 years? If the percentage of change programs that failed to achieve their objectives was 70%, what do you think this might be? Helen, have we got any numbers?
35 to 40% we're at the moment.
Okay. Okay, again, still relatively low. According to them in 2022, that was 67%. They're quite frightening figures, really, aren't they? And according to the Capability of Change Global Change Survey results in 2024, When you look at how you describe the changes in your business from 24 to 23, look at where the main figures are. Even above increasing operational efficiencies is increasing digitization. The reason for that is because it's seen as increasing operational efficiencies. So digital has to work. And what's stopping change being effective in your organization? Well, change management activities are not understood, is the main one. Right down to change management not being valued. The fact that there are no barriers there for about 3% is quite interesting as well. So what does that mean to us? Well, for digital effectiveness, we need 4 things. It needs to be appropriate for the business need. We understand this, and it's why we have business analysts and benefit managers to focus on whether there's a need to support the business. It's then got to be adapted to the business environment. So business analysis, analysts and user experience professionals focus on how the digital needs to work in a business environment. It then needs to be accessible, and we've got UX and UI professionals focusing on how accessible it is. But then we tend to stop. And that's the bit that we're missing, because it also needs to be adopted. Because if we overlook that, we are literally just creating the tech. It must be adopted. And post-adoption is where the appropriateness of that solution, going right back to the beginning, is challenged through realization of the benefits. It can only be done through efficient and effective use of the solution by its intended users. So we have the technology, we have the process, and we have the people. So what do I mean by change management? So what's the difference between change management and business change? They're often seen as they're seen as interchangeable, but they're not. So we've developed the change onion, or the chunion as it's now become known. And at the core of that is some sort of tech. It's usually focused on tech, but it enables the physical capability, whatever it is that you're trying to change. We've then got the business change, so the process of moving from current to future state processes. So we're establishing those new business processes. We then have change management, which is the art of bringing people on that journey, moving them from current to future state. That's about understanding why and winning hearts and minds. And only then will we achieve the utopia of transformation through adoption. Now, there's quite a lot of research around this as well. So I'm going back some way. Beckard and Harris did this lovely change formula that says that for a change to occur, the level of dissatisfaction with the status quo, the desirability of the proposed change, and the practicality of the change, so the next practical steps, must be greater than the perceived cost of the change. That's really important as well, that it's the perceived cost of the change. So it's about people's perceptions of what that's going to cost them personally. So in other words, for change to occur, it must be greater than the dissatisfaction, the vision of the future, and the first steps to achieving that vision must be greater than the resistance. So again, we've developed 6 critical questions that need to be answered for digital adoption success. The first is, why are we doing this? And I don't think we ask that question often enough. And because I said so isn't the right answer. Once we've got the answer to why we're doing it, then what will the future look like when we get there? Thirdly, what might prevent us from achieving the vision of the future? Who's going to be impacted by it? Who's leading the change? And that's not just senior leaders, it's top down and bottom up. And then finally, how will we persuade people to change? And without the answers to those questions, we will just carry on sailing to nowhere. So as you can see, I've used AI to create some graphics to help tell this story. So we are on our ship at the moment, but we don't know why. we've just boarded the ship, but we've no idea why. And then we see the vision of the future. We see this beautiful island with the sunshine and it looks beach worthy. But then we can see that there might be things that are getting in our way, things that are holding us back. We're being driven back from the island. Who's impacted? Who's going to get on that boat to the island? Who's driving the boat? Interesting that AI came up with a captain that looks like Captain Birdseye. Couldn't have been more predictable, could it? And then finally, how are we going to get people to change? How are we going to get them there so that and AI left some people in the sea on the left-hand side there. I couldn't get them out of the sea even when we've all arrived on the island. So apologies for that. I did try. So to do this, we have a standardized approach. The approach includes 5 phases, what we're calling pre-discovery, where we define the change, solution design, where we prepare it, development, where we plan it, deployment, where we manage the implementation of the change, and finally post-deployment, where we reinforce and sustain the change. And change management often has a problem because change managers get involved far too late. They're called in around deployment when the project says, oh, we've got to go live in a few weeks. Maybe we need to talk to people. We might have to get some comms out. Of course, where we should be involved is right at the start with defining a change vision and creating a compelling case for change. We have some tools that will help us with this. So the 6 critical questions, the first one, why we're doing this, we're looking at what's driving the need for the change, and we can use force field analysis, driving forces to do that. What will the future look like? We can create a change vision. What might prevent us? Force field analysis, resisting forces. Who's going to be impacted? Stakeholder analysis. Who's leading the change? Top-down sponsor coalition map, bottom-up change network. And how will we persuade people to change? How do we create a compelling case for change? All of these tools and more can be accessed via our change management network. And I believe that Helen is going to drop a link in the chat if it's not there already. So we currently have almost 3,000 members who are supporting change, particularly around digital across health and care. We also run events of interest. So we've got monthly webinars covering change adoption, digital adoption, networking. So again, we've got a couple, crafting your change vision was last week, and recruiting, developing and nurturing a change network is just coming up. All the recordings are there as well. We've got our change management toolkit that has 80 odd tools and techniques embedded, but they're also available on the network as standalone. And I encourage you to take a look. So there's something for everyone. So in summary, technology is a small part of the answer. Process is slightly larger. The people are everything. And we need to remember the 4 A's to really bring digital adoption alive.
Fantastic. Thank you so much, Julie. That was a brilliant insight. And in such a short amount of time, a really clear and compelling case for why change management is so vital for digital adoption.
Thank you.
Any questions for Julie, if you stick them in the Q&A and in the potentially in the chat, we will pick them up at the end. But yeah, some fantastic resources that link to that to support you with your digital transformation. And now we're going to move on to a case and example, and particularly given the government's priorities at the moment, not just from analog to digital, but also from hospital to community. And Tara Marshall from These Hands Academy is going to tell us more about a case study that really puts some of this stuff into practice. So if I can hand over to you, Tara.
Hi, yeah, thank you. And Julie, you absolutely set the floor for this. So I'm so pleased. I came to talk to you a year ago now around this programme. And at that point, it was very much in its infancy, but we had a huge impact. And we've managed to scale it, and our story and the story of the people that it's impact has enabled that future funding. So I'm back to tell you about year 2. So a little bit about me and These Hands Academy. We are growing. We are a small organisation that has essentially stepped out of the NHS to leave a legacy, because that's what I want to do. And we've brought with us all of our experience over that time. So I'm trained clinically as a nurse and have spent just nearly 30 years now working in and around the NHS, and have worked my way from right down to being a student to right up to a regional level to implement change across the NHS to improve standards, create efficiencies, and inform future planning. And that hasn't changed in where we're working now, apart from we are now working across the social care sector. And we're trying to take a small fraction of what I did clinically into that space by using digital and technology. And one of the programs that specifically we're going to talk to you today is about the LLR Connected Care Programme. And that's an initiative that is a partnership across Leicester, Leicestershire and Leicester City councils that originally funded this, and has now been adopted by the ICB to scale this across to all of their areas. And it's focused on social care. It's focused on originally residential care and supported living, and that's where it grew, and it's now growing into their dom care services. And together we look at where this programme impacts people, how it grows, but we have a key message. And that message is around the foundations of why we're worried about people. And this seems a really simple statement. If you're worried about somebody and you need help, are you being heard? And the answer for a lot of people is no. And that's not because people can't hear us, it's because they're often not talking in the same language. So what we've done is leveraged the National Early Warning Score to use that digitally and verbally so that people are heard across the system, because it is the one common denominator across everything that we do. And as we grow into a more digitally enabled worried well group of people, a lot of us have got our smartwatches on now. I'm sure if you take it to your GP, are they interested in the data? I'm not so sure. But what we don't want to see, and for me, this is my mission, is anybody deteriorating unnoticed, because they don't have access to some of this equipment. And there is a divide between our nursing homes, our residential homes, and our supporting living. And yet residential classification under the CQC make up 70% of those spaces within our community under our care home network. And they are the group that don't have nursing footfall, and they rely on people coming in and out. So this is Malcolm, who I like to call Malcolm, I refer to him. This is what we don't want to see, and this is what we are trying to do by leveraging technology, but also keep it affordable for our councils to invest in. And we've connected that with policy. We've got the Darcy report that we're all very familiar with, but this is about enabling communities and enabling people in their own home to use this equipment and use it well. So we try as much as we can to dig into that and understand where it adds value and which type of equipment adds the most value to the right people. Underpinning everything that we do as we move from the NHS into community is the peer framework. And that's about managing deterioration, but also identifying it early. So everything that's in the green arrows that you see through this slide pack are our opportunities to get there earlier, to create more time and release time to care. By the time that we have got to in the red to the response, that opportunity to make a difference, get there earlier, has already passed us by. And the further that we live away from our hospitals in our community, the harder it is for people to get to you. So the more time they have to make decisions is a great thing, but if they haven't got the information at hand, then they can't do that. And that's where telehealth really does make a difference, because people can use this regularly. And what we've leveraged is one box. Some of you will be familiar with this box, but there are lots of them. And they have all the equipment in to take a set of vital signs. So essentially the National Early Warning Score. They are Bluetooth enabled so that there is no writing down, there's no tapping on screens. All the information is transferred across verbally and it's repeated. So everybody can use it and everybody can hear it. But also it means that nobody has to leave the resident that they're looking after. And again, everything in the green are the people that we can send this information to. So we can connect this into our care records, our GPs through System 1, and our response teams through an interface to 111 services, or some of the other services that work around LLR, and DHU is one of them. But we are connecting these into our therapy teams and our dom care services. Underpinning again, that is our quality outcomes framework, so our GPs are interested in it. We also have the enhanced care home framework as well, which it absolutely aligns to. And again, we've got that red, yellow and green structure underneath it. So we're starting to see that where our key points are. And of course, we are starting to move things into the green, and that's what this project is trying to do. We were ambitious at the beginning, and we first set out on this over 2 years ago now and unlocked funding to get to 25% of homes across LLR, and that's roughly about 9,000 people. We grew this organically by connecting into all of our managers, the staff. We must have presented this to 200 different platforms now, where you start to think about how you get that engagement socially. And we have absolutely focused on proactive and preventive measures of care. And we've reached 37% now, and we've had to be really resourceful with the resources that we had. We had funding for 25, so we've managed to get over 3,500 people now at one point on this system, which is a huge achievement with such a short pot of money. And we want to do more, but part of that is having the evidence to do it. The group that particularly ran with this were our group in supported living, and I'm sure some of you will visit the website. I've not put the video in there today, but Chris is one of our champions for this. But for him, it's made a huge difference. He's gone from being worried about his health to being out sailing, which is exactly what he should be doing. So where are we now? We've got year 1, 20 homes, 800 people. Year 2, this number is growing every day. And this is from the pilot to scale evaluation. But we've got up to 3,500 people now that are being supported on a very short piece of money. We can have up to 40 people on one of these systems. So it really does reduce the cost. But where we've really made a difference is when people are using this regularly, because it provides a baseline. It provides something for somebody to work up from, and some really accurate and vital clinical information that gets handed over to clinicians. And alongside using this technology is the real impact of training. So this is where our training is about early recognition. It doesn't focus on so much on long conversations, it focuses on numbers, but it also enables a complete standardised language that we use across the NHS in all of our organisations, our mental health trusts, our ambulances, all of our technology that we're putting in. So whichever system people are putting in to social care environments, if it's clinically enabled, it will have the news score on it. So we allow that commercial competition to still be within that space. And again, we think about how people talk within that system. So it centres around anatomy and physiology, but it also focuses on the people that know their residents the best. Our care home staff spend the most time with those residents. They've got vital information that we're not collecting because we either don't hear it at the front door because we're not talking the right language, or we're just not hearing it in the noise of all the different processes that people have to go through. So that one long conversation is now a number, and those numbers really do have a much bigger volume. And we are seeing changes. We are shifting the dial now from red into green. And we are absolutely starting to see that by regular use, we can change lives, as in make a difference to people living well where they are. So their scoring is starting to reduce as their numbers are levelling out. And that's because we've got them in regular use. The other impact at its heart of this is about people. This is about people being more informed, more proactive. And yes, we've saved money, and that money has to demonstrate that we could do more with it. We have to tick that box. But from a return of investment, it's about 80% now, because we are not using it as a virtual ward model, which is clinically expensive. It's very much enabling people to use this at home in their own homes. But 100% of people that have gone through this programme have said that their confidence has improved and that they feel heard by using that common language. And the other really nice thing to see is that people have put policies in place to support it. So this is new, it's of added value rather than something that is coming down and being led from the top. So where else have we been in the last 12 months? Well, we've been talking to our research partners. We've got our care homes involved in a project with the Leicester Institute for Advanced Studies. And rather than our homes having to go to them, we took our researchers to our homes. And it made a huge difference because our homes can't release their staff to go to these events. So we did it the other way round, and it's worked really well. The other thing that we've done out of here is, yes, it is a huge saving, is we've started to think about other countries, and we got involved with a piece of work with some data analytics students in Canada, and this paper is being presented over the weekend. But we started to look at their areas and how telehealth might support their underserved populations in rural spaces across Canada. So if you think what we can do in our tiny island, what they can do in their country with using this is huge. And if we can empower people to live better at home, then we have to be able to reduce the impact on the front door of a hospital. Actually doing that is where the hard work is. But we go back, we find out what people think about it, we make changes, we iterate as we go along, and we absolutely use their voice to inform what we do next, but also think, how can we add more value to what's happening now? And that's where this project has grown absolutely organically across the work that we're doing. And we have introduced Maggie and Malcolm now, and we are building communities with people that have confident voices. They bring their families along, and they have absolutely strengthened the relationships between social care and healthcare services because they can make a difference. But most importantly, we're keeping people where they want to be in the place of their choice. And for Chris, it turns a crisis into a preventable solution, but it also allows him to go sailing and have a lot of fun. Now, Chris has a learning disability and will probably live 10, 15 years less than we will. Now, I've got a bucket list, and I'm sure lots of you have got a bucket list, and he should have a bucket list too. So before I finish, I always have to do an impact statement, and this is one of them. So there's two of them in here. But for us, it's about ensuring that nobody deteriorates unnoticed. But we've got 67 million opportunities in this country to enable that to happen. And by focusing on what goes right in some of these projects, rather than the 10% that goes wrong, we can start to think about how we move from trying to fit a square peg into our social care hole, because they are huge innovators. They will tell us what works for them, and they will adopt change as long as we work with them to do that. You can find, I know I'm here today, but actually this is about their story, and this slide will come out to you, but most of these are from the people that we work with, and that's about them having their story to get out there. So just imagine if we had one more home, one more provider, and there's 5,500 providers out there, one more of the 42 ICBs come and adopt this kind of programme, because the benefits really do speak for themselves, and we absolutely can move, not all, but some of hospital to home. And I will stop it there. And I have equally just remembered that we did have a Mentimeter in there, and I've forgotten to put it in because I'm so busy telling that story. But let's put it out at the end and drop out for questions.
Fantastic, thank you, Tara, and rightly so. The amount of applause that's going on, because that's such a stunningly fantastic example of how the technology, but also the compassionate engagement in the needs of the clients and the residents and the population out there can be used to make that quality of life and health improvements just really make a difference. And do have a look at those videos of the users of those services, because they tell some absolutely fantastic stories and incredibly moving. So thank you, Tara. That was a brilliant insight, and I think everybody will agree we've had two really fantastic very short presentations from both Julie and Tara, and what fantastic insights from both of them in that short amount of time. So who has questions for both Julie and Tara? Stick your hands up. I've got a couple of questions ready in the wings, but do ask them, because this is your opportunity. All the slides will be shared, the links will be shared. Tara has done a fantastic ebook that's been dropped in the chat, which talks about the pilot to scale. So make use of that and access that. Julie's change management group, and also the absolutely fantastic toolkit that will help you plan and manage that change, is all there in the links. They will come out to you in terms of an email along with all the links to both FedIP, HPCA, and both Julie and Tara's work. So if you've got a question, please do. I mean, this is your opportunity to find out more and ask about those things that are challenges in terms of planning and implementing these kinds of things. Do stick your hands up and we'll come to you. In the meantime, Julie, can I start with you and ask you a quick question? It may be a quick question, may not be quite so quick.
Question might be, the answer might not be.
Yes, exactly, yeah. How do we integrate planning for the people side of change as part of the technical development?
Okay. That is not a quick answer, is it? So,
it's a good one.
Yes, it is. So I keep going. We have this challenge within NHS England, as most people will be aware. So somebody says, I've got a great idea, we're going to develop this doobie dangle, and they go, oh, that's great, yeah, we'll get some people to develop this, and then the world will buy it, and everybody will use it, and it'll be wonderful. And then they hand over to us a bit too late around deployment time, and they say, can you make people use this, please? And we really do need to make them work with us sooner. One of the ways we're doing that in NHS England is by working with our PMO, who are now insisting that they need that the business cases need an element of digital adoption to be recognised in their business case. Absolutely brilliant, really pleased. And that can be done if you work with your internal PMO. The other way we're doing it is by getting the programs to answer those 6 questions. So right up front, we work with the programs and we get them to talk about why they're doing this. What will the future look like for people when they've done it? What might prevent them from doing it? And we have actually had elements of that there has been at least one program that came to the conclusion that it wasn't worth doing, which is great.
Wow.
It really is, because of going through those questions. So first of all, talk to your PMO and get that compliance area, and then engage people early and getting them to think about the answers to those 6 questions. Sorry, it wasn't a particularly short answer, was it?
No, but an important one. And I think knowing where to start is a really important part of it in terms of how do we move from where we are now and change some of those behaviours that starts the journey off in the right way. So fantastic.
And I would say, get yourself, don't be frightened. Shy Bairns getting out. Talk to people. Don't wait for them to come to you, because they won't. The technical delivery will carry on regardless. Go in there and get to them instead.
Fantastic, thank you. We have a hand up, which is Emeka. If you would like to ask your question, that's fantastic. Anybody else that's got a question, stick your hand up, because this is your great opportunity. So Emeka, if I can come to you.
Thank you very much, Joe. Thank you very much for your wonderful presentations. My question is actually towards Tara. I live down here in Essex, and I've done some work with some care homes, and I know firsthand how your work can actually benefit most of the care homes here. However, I also know once you start talking about any type of improvement, the first question they're always asking is, how long is it going to take? How much it's going to cost? So are you able to just give us briefly on average what it actually takes you to deploy that out?
So there's two questions to that. One of them is, it's not how you use the equipment, it's why. And for the length of time for deployment, this is about changing habits. This is also about messaging from the NHS, who say you need to use this reactively. No, this is a proactive care model. This is something that we start to use over time, and we change people's habits. So we've been working with this programme for nearly 2 years now to do that. But actually the hard work was really at the beginning. Now we've grown a community of people that are all starting to see the benefits of regular use, and they're all absolutely starting to think about doing the same thing. So they're all learning from each other. But our barriers in there has actually been, sometimes it's been that health intervention saying, no, you shouldn't do it proactively. We only work reactively and only use it when you're worried. We want people to use stuff like this routinely. So there's lots of different barriers and trip ups and fallovers that you have to go round, but the way you learn about that is by listening to the people that are using it, keep in touch with them and help them to support it. So this model essentially that we've developed is something around sustainability and how we can absolutely start to drive this forward by creating as well a demand for that data by wraparound services. Because if people aren't listening to the care homes using this, then they'll stop using it, because why would they? So it's about a whole system solution. Does that help?
It does. Actually, also helps me, because that's also going to change my approach to talking to the care providers I'm in contact with. Because for me, this is actually a very, very, very unique and special tool, because like you rightly said, it's good for us to be more proactive than reactive. Yeah, thank you very much.
You're more than welcome.
That's great, and a great question. And also, I think contact details, Julie's got her contact details sort of on the screen, but also Tara, you shared yours in your slides, and we will share those afterwards. And I'm sure you'd be happy for people to get in touch and follow up on any particular opportunities to ask questions and also to share. There were some comments in the chat. We do have a question online, and if anybody else would like to ask a question, do put your hand up. So somebody's put a question in the Q&A that says, I think this is for you, Julie, but you may both have an opinion on it. If a decision is made nationally to implement a digital solution which hasn't been assessed locally, i.e. requirements, reviewing existing systems, how can you implement a system within hospital which clinicians are categorically opposed to?
Oh, if only there was an answer to this. We all know the answer is with great difficulty. And I've got this big thing about commitment versus compliance. We will get compliance if we insist on it. If we beat people with a stick, they will eventually give in and do this. But we really don't want that. We want commitment, and the only way to get that is for people to understand the real benefits to themselves. So first of all, if they are categorically opposed, find out why, and don't ever be concerned about feeding that back. It's really important that if we have absolutely valid reasons why people have do not want to do this, then whoever's up high that have said it's got to be done need to know that. So please feed it back. But secondly, it could very well be that the categorical opposition is actually because of different reasons. They may be resisting for lots of different reasons, and we could possibly persuade them, probably on a one-to-one basis where that's the case. But talk to people, just find out why is this being implemented from above, and why is it being resisted from the hospital. That'll help you to generate an understanding that will help you to either convince them up top to stop doing it, or convince them in the trust that they really should be thinking about adopting it.
Okay, thank you, Julie. That's great. There is a question in the chat aimed at you. It's about the network. So somebody has signed up for the future NHS pages to access the toolkit, etc. But she's also asking if there is an internal network, so somebody within NHS England.
Oh, not within NHS England. No, we're not internal. We are absolutely open. So our futures network is our internal network as well.
Yeah, so open to everybody. So don't be put off by the fact that it sort of says it's part of NHS England. It's there to support the whole sector to improve, and not just the trusts. Social care, primary care, everybody has an opportunity to access it.
Yeah,
absolutely. Thank you. Any more questions for either Tara or Julie? Just having a quick look. Okay, so we've got one in the Q&A section. So one from John Williams. I'm interested in your thoughts around how AI can be used to support change management methods today. Great question, John. Julie, did you want to make a start on that? And then Tara, if you've got any thoughts.
Absolutely. AI is both a threat and an opportunity, as we know. First of all, it depends what we mean by AI. So if we're talking about something like Copilot, it's really useful in lots of ways. In terms of summarizing documents, it's useful just to get the creativity bug going. But we also have, watch this space, we have within our change network, we have a brilliant opportunity. It's a gaming machine, basically, that will help people through scenarios to think about here's the situation, what's the best option to get adoption, to get engagement, to reduce risk, etc. It's a really fabulous little gaming tool that uses AI, and it's so good. We're going to launch it in the network very, very soon, but we'll also be launching how it can be used, how it can be adapted by anyone in the NHS. It's going to be open source because it's been developed within NHS England, so it's going to be available to everyone. So watch this space on AI. Watch out for CADAS. So I'll leave it there on that one, Tara.
Can you spell that in the chat so that people can go away and ask ChatGPT what it is and how they can use it?
You won't be able to find out yet because it's under wraps. But
there's
if you're in the network,
there's a teaser for everybody.
It's a teaser.
Yeah. Excellent. And Tara, your thoughts on that?
So I think I'm like Julie. I think, people are going to be reserved, but I think there's a huge opportunity there where we can use AI to learn about systems and its behaviours. And just imagine if we knew where our next ambulance needed to be, and we could plant it 10 miles closer to that home. Just imagine if we could get the blood bank to be where predictively that next hospital needed to be. And we're almost there. But there's a huge, huge opportunity in this, and we're starting to think about how we do this, and are working with Loughborough University. But I mean, it's a bit like the old advert of the possibilities are endless. Potentially they're there. I'd say the opportunities are endless. But if we can improve care delivery because of AI, I can't think of what's not to like.
Yeah, absolutely. I agree. I think there is so much potential. I think what we need partly is we need some sensible data governance and some assurance around it, but also some open minds and that curiosity to experiment and to learn. Sarah, can I just ask if you have spotted any other comments or questions in the chat that you might want to flag up?
There's just one from Barbara who asks, how do you establish the baseline and understand the improvement gap? So small question to end with.
So I might be able to help with a bit of that with the work that we're doing. Is we go out there first and find that baseline, and then we build from it. And we monitor that regularly. So if it's not working in a patch, we try and understand why, and then think what's different now. But if we think of baselines for clinical observations and then apply that to projects, so from people to projects, actually we know our own baseline, what's working well for us, what makes us feel better is actually what's probably going to make your project feel better, because it makes you feel better delivering it. So there's something going right there. And then if the bit that isn't quite right, go back and find out why, because you do that for yourself, so do it for your projects too.
Thank you very much. That's great.
I'll leave on that one.
Yeah. Did you want to add anything, Julie, or are we happy with that?
Yeah, absolutely agree with Tara. But for our projects, we have change management. We have what we call a change readiness review. That basically has got some statements based on force field analysis that if the some were true, then there's a better chance than if those were true, there's a less chance, and it gives us a baseline score, and it's not compared to anything else, but it's their baseline. It's that program's baseline. We then develop an action plan to increase that score, so that and it's great when they're doing something and they can see the score shifting. Particularly for large EPR implementations, it's been really helpful. And it also means they've got something to go back to their board with that says, look, this is where we are right now. And it's not going to get any better unless you invest in the change.
Brilliant. Yes, absolutely. And can I just say that is part of the change management toolkit, that change readiness assessment tool. So do register for that and do access it, because it is absolutely fantastic resource. Thank you both again to Julie and Tara for your fantastic insights and brilliant work. All the links to everything that's been talked about will be included in the email that will go out to everybody tomorrow, along with a link to the recording and also a copy of the slides. So anything that was in there, you'll get to see that and be able to reflect on it, have a look. But also don't forget to register for FedIP, don't forget to register for HPCA. Do sign up for more events. I think these have been really popular. So what we'll do, Sarah, if you're happy to, is we'll look for other topics that we can come together on and share across the respective communities and bring that knowledge and skill together. Please do fill in the feedback form. It's really valuable to us to let us know how these events are going and what else we can put on in the future. So thank you again both, and for everybody who's participated, it's been another great session, and hopefully we'll see you all next time.